Maternal mental health, a foundational element of societal health? Welcome to Talking Psychiatry. In this episode, I will be in conversation with Lavinia Lumu. Lavinia is a psychiatrist with a special interest in perinatal psychiatry. Lavinia sits on the executive board of the South African Society of Psychiatrists by virtue of her involvement with the Women's Mental Health Special Interest Group. Lavinia is the current president of the International Marseille Society for Perinatal Mental Health. She most recently published an article in South African Psychiatry, the March 2026 issue, entitled Why Maternal Mental Health Still Matters. That'll be the focus of our discussion. Let's join Lavinia. Lavinia, good to see you. Glad you could make it, and thanks so much for taking the time.
Thanks for inviting me, Prof.
Great to have you. Now, I haven't seen you in person for a while, but I know we've had contact, so that's why it's really nice to see you. I wanted to start out just a very, I suppose, basic question. Perinatal psychiatry, your interest in perinatal psychiatry, what is that, and why are you interested in it?
Yeah, it's quite a story. It started way back when, roughly 10 years ago, when we were still working together. And that's why I'm still gonna call you Prof, because
Okay, whatever makes you feel comfortable,
yeah,
that's fine.
yeah. So it was Ward 487, and we were just
Yes.
having a lot of pregnant women during that time being admitted, and that's where my interest sparked in terms of what are we doing in terms of managing women in pregnancy, what medications to give them. So working with the obstetricians, and I think for me that's the birth of where this stemmed from. And in that same year, in 2016, I started doing research, trying to find out, like, what is this perinatal psychiatry? And then that's when I discovered the International Marseille Society for Perinatal Mental Health. And they were having this conference in Melbourne, and I was fortunate enough to go. And hey, it was like going to church and being born again, as they would say. And since then, I haven't looked back.
Well, I suppose, yeah, that's how it often starts. It's exposure in the clinical domain, where you start to see cases and they catch your eye and they catch your interest, and then begins the journey. And it's really great to see that something that started out as a clinical experience, a clinical exposure, has turned into something so much more. Which brings me to your involvement with women's mental health and the Women's Mental Health Special Interest Group of SASOP. What's that all about, and what's your role, and what's your agenda, actually?
Yeah, so from that experience, I then started trying to find people in the country who would also be interested in women's mental health. Touched base with Dr. Bavi Vitiligo, who's based in Cape Town. We had a conversation, then met Dr. Elsa Dutoit, and then casually the three of us were like, hey, when media needs sort of interviews around women's mental health, us three would juggle and sort of spread the word and
Right.
advocate and spread awareness around maternal mental health. And then that's how the Women's Special Interest Group started, just with the three of us. And then it morphed into a WhatsApp group. And then from the WhatsApp group, here today, we have a whole special interest group within SASOP.
Okay, well, that's excellent. Tell me something as a matter of interest. Is there a men's mental health special interest group or not? Not that I'm volunteering, but I'm just wondering.
So, that's why some people prefer the term perinatal mental health, because it's more sort of inclusive.
Yes.
It's more inclusive. We actually also have within the Marseille Society a
Yep.
father's mental health special interest group, because we do also see postpartum depression in fathers as well. And interestingly enough, use the same Edinburgh postnatal depression scale as well. So yeah,
Interesting. I mean, I've heard of that. I can't say that I've done a deep dive into it, but that's interesting because I think that also we will touch on this the role for fathers in perinatal health per se. So it's obviously mothers first and foremost in that sense, but fathers are very much part of the deal, and I think that's very important. You know, there's a lot of concern about absent fathers and the role of fathers in society generally, and certainly here in South Africa that has been an issue. And so, not that we're going to get into that specifically, but it's very definitely a part of what we're going to be talking about. The International Marseille Society for Perinatal Mental Health. A little bit of the history, its origins, what it's all about, just so that folk get a sense of what is this organization.
So yeah, it's a international society. We have members from over 70 different countries throughout the world. Average membership is close to 1,000 members, and we have biennial face-to-face meetings, and in between we have meetings in the different regions throughout the world, and webinars as well. And we have a listserv and offer sort of support for anyone who is in the perinatal mental health space, from clinicians to researchers to advocates. It started in 1982 at a
Yes, so
meeting.
it's not that old actually.
Yeah, it was like at a psychiatry meeting at a biological congress. They had a meeting. It was like a few people who were sort of interested in this space, and then they're like, "Hey, let's start the society." And the society was named after Dr. Victor Marseille, who was the first to describe this phenomenon of uh, a syndrome or an illness that sort of manifests in the postpartum. And my French is really bad. Uh, all my lessons with Alliance Française, all that money gone to waste. But it's something along the lines of
I'm sure you've got some foundation there.
treatise or something like that. But basically
Yes.
manuscripts
Yeah.
describing the postpartum state in women.
But going back to 1858, from what I saw, so I mean, that goes back, over a century. And then, of course, the society was formed, and it looks like you have grown significantly and you've become a force in that space. But I mean, just looking at the aims of the Marseille Society, I mean, I see research, education, international collaboration, clinical guidance, best practice, and advocacy. So, I mean, there's quite a spectrum of individual agendas in the overall agenda. But your role as president, I mean, when did you commence and how long does it last for? And I know that you've got the International Congress coming up later this year in Cape Town, which obviously South African society is comfortable and happy to promote and will definitely, continue to do so. So just in terms of your role as president and the forthcoming Congress.
So all those years ago in 2016, I did not think for the life of me that one day I myself would be president.
Yes.
I was just sort of a member and then enjoyed the exchange in knowledge, because I mean, little is understood about the space. Getting to meet great researchers in that space, and people who have more experience in the field in terms of managing this period, like the Harvard Medical School as well runs a weekly ward round for perinatal psychiatry as well. So meeting all the greats coming together. So it so happened that there was another South African. Her name is Prof. Simone Honigman. She was on the
Yes.
Marseille board. She was on the Marseille board, and then she had other commitments and sort of reached out to me and said, "Hey, Lavinia, I'm too busy. I don't have time. We really want representation from South Africa on the board. Would you like to join the board? You just attend a meeting once a month. You don't need to say much." just attend, and it's online. I was like, okay, an online meeting, that's fine. So that started out in 2022. And then after being on the board, I was approached in the middle of 2023 into 2024 to be president-elect for the society. And I'm like, me, little old me. Yeah. And then they're like, no, we're confident to things. I suppose being from South Africa, being quite opinionated and making sure
Sure.
that our voice is heard, because our needs are slightly sort of different, our perspectives are slightly different from the rest of the world. Keeping that alive, I think that's why I landed in the role of president-elect. And then as of last year officially, I started being the president of the society. Um, this is my last year. I'm going to hand
So it's a
over
two. So it's 2 years,
2 years.
right?
Yeah. And
So your
then
swan
also
song. So you got the Congress coming up in September. So that's like a
in
big deal.
September, big deal. And it's a big deal because this is the very first time that the society in its history has had a conference on the continent of Africa, and the very first time in South Africa, because traditionally the conference has to take place in the president's sort of home country to sort of host it. Yes. So that's how we are where we are. And yeah, and it's unique because we are a multidisciplinary society. So we have psychologists, we have social workers, we have lactation specialists. You can be a
Okay.
pediatrician, obstetrician, gynecologist, as long as you're in the sort of front line of perinatal
In that
mental health.
space.
Yeah.
Yeah. That's fantastic. So it's very diverse, inclusive, and I mean, you've got broad representation. It's that multidisciplinary, which is much more holistic in the sense because, I mean, you know, you need all of these different players. So I want to get to your article, and the issue of maternal mental health. Immediately, my mind goes to pregnancy, but I suddenly realized, no, 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 it's maternal mental health. So you don't have to be pregnant to be in that space. This is for all mothers per se. Doesn't matter when you've delivered. So it's quite a broad term. But you then use the expression or the phrase still matters. So it's why maternal health still matters. And I thought to myself, did it ever not matter? So there must have been a motivation why you titled the article that way.
Yeah, so I think the reason why I said still matters is looking at it from a clinician point of view, and I reflect on my training. um we never sort of distinguished women of childbearing age and what medications sort of to be aware of and the impacts thereof, and also in men as well. I also recently gave a talk on prescribing you sort of infertility in sort of the fertility space. And I mean, what's fascinating is that there are also psychotropic medications that affect male fertility as well. So,
I think that's quite an interesting issue,
sorry,
which I don't think we. No, it's okay. We just keep going. This is a this
yeah,
is a podcast that relies on this technology that is not necessarily perfect, and at the end of the day, we just keep going. And I might even just keep this in because it's real, it's authentic, right? It's what happened in the conversation. So I think the point
yeah,
you've made there is a very interesting one because I don't think that there is much discussion around male fertility and psychotropic drugs.
yeah. So, I mean, there's more research actually looking at, um, what I've learned on my journeys is conscious prescribing, right?
Yes.
We
Okay.
we
That's a
are,
nice
we are
term.
not
Conscious prescribing.
we we are not conscious. Like, people think psychiatry, like if you speak to non like our colleagues, they
Yeah.
still
Our
stuck
colleagues.
Yeah, haloperidol. You're like, yeah, you just give psychiatry is easy. You just give haloperidol and fluoxetine, and that's it. There's nothing to it. Um,
Yes.
but like on this journey, I'm more conscious. Yeah, conscious prescribing. I mean, psychiatry is a complex science and art of individualized sort of treatment to improve a person's functioning. I mean, that's how I view it. And sometimes we just prescribe, but we are not conscious to the impact of the medication that we prescribe. And this is a woman or this is a man. If they fall pregnant, what will happen to the fetus? What will happen to the children? And if it's untreated, whatever condition we're
Yes.
treating, what are the impacts on the offspring? So yeah, so it's a layered and sort of complex approach to psychiatry.
Well, I think that that is something that is so important because what we're saying is that, yes, there are general guidelines, but then you get down to the patient themselves. And I think that you need to be able to apply your knowledge within that context, which means that you really need to know and understand your patient really well. You develop a very intimate understanding of who they are, where they're at, and you're not necessarily just thinking about the present, you're also thinking about the future and the implications of your treatment. So I do think that that is where, as psychiatrists, whether we even realize it or not, we're very thoughtful in terms of what we do. So this conscious prescribing is something which is just kind of part of who we are, actually. And as I said, we don't even necessarily even think about it. But going back to the article and just looking at your opening paragraph, I mean, there does seem to be a sense that there might have been, still remains, some neglect, and you bring various factors together. You speak about the intersection of various factors. Do you want to elaborate a little bit on that?
So and that's why I even said still matters because I think there has been a neglect in terms of being conscious of our patient and being holistic. And these factors that influence it is stigma. I think stigma is huge still in our space. Do you know everyone
Sure,
speaks and that lingo, but
sure.
if we get down to the crux of it, people are still
Yes.
uncomfortable with being diagnosed with a mental illness. And if someone is pregnant or trying to fall pregnant, the immediate reflex is to want to stop the medication. And what often saddens me is it's our own colleagues who encourage discourage patients from continuing the medication and creating this fear, and neglecting the fact that untreated illness in itself has sort of dire outcomes.
Absolutely. And I'm going to come back to that specifically because I think that's a very important point. But I think the point you're also making is that greater awareness doesn't necessarily lead to necessarily less stigma or more investment in addressing some of the issues that we're going to be speaking about and psychiatry generally. So you speak about, limited mental health resources, high burden of disease, structural inequality. So you're looking at various factors that come together to ultimately create what I think we're talking about, which is the gap in resources in terms of providing for care of psychiatric patients generally, not just in terms of maternal mental health, but psychiatry as a discipline generally. But then you move into something quite dark. You start talking about ethics. And I think there it's very important just to spend a little bit of time looking at the history around the issue of compulsory sterilization and the Nazi era. Do you want to elaborate on that? Because I got a few thoughts.
Yeah, so I history fascinates me. I mean, I didn't do it in high school, and
Me
yeah, that
neither.
was my biggest regret. But psychiatry has a dark history and a
Is
very
it
dark history.
psychiatry? Is it psychiatry or how psychiatric patients have been treated? Because it
that's
could
a
be
that's
psychiatry as well.
yeah, yeah. Because I mean, a lot of some of what we use today was kind of, yeah. So the treatments, would I say, the history
Okay,
of
fair
the
enough. No, no. Okay, fair
treatment.
enough. You're being more specific. Frontal
Yes,
lobotomies, etc.,
yes,
etc.
yes,
Got
yes.
you.
Very.
Okay. So, but if we're getting into the issue of compulsory sterilization and the history and where psychiatry was impacted, sorry, carry on.
Yeah. So I think the compulsory sterilization in that time, in the Nazi era, where it was we were trying to create this perfect Aryan race, it sort of
Yes,
speaks to how, the stigma around being diagnosed with a mental illness. And I think during that era with the compulsory sterilization is to make sure that these bad genes do not, sort of transfer and
great.
sort of
Yes.
contaminate, if you will, uh, then the future generations to come. So I think why I put that in is it sounds sort of barbaric if we, hear it say like, "Oh,
Wow.
sterilizing
Yeah.
people with
Mm.
mental illness." But in a way, it's sort of the birth of and the origins of this stigma and this fear around, having a dread diagnosis of any sort of
Yes.
mental illness. Yeah.
Well, I think it speaks to stigma more broadly within psychiatry, but obviously the forced sterilization. And here we're talking about individuals with intellectual disability, epilepsy, schizophrenia. So, and I think that the idea of genetic purity comes to the issue of eugenics. And so when we think of eugenics and we think of that period, I mean, it's like, arm's length. However, just the other day, I was watching a podcast and I came across a young man called Kian Sadeghi. You may or may not have heard of him. He's the CEO of a company called Nucleus. And so the debate or the discussion was, does your organization ultimately practice eugenics? Because basically what they do, this is for in vitro fertilization, they do genetic screening, preconception. And so the issue is to select embryos for the least possibility of heritable diseases, as well as you can also determine eye color, hair color, height, intelligence. And so the question was, well, aren't you practicing a kind of eugenics because you will discard those embryos or retain a specific embryo? And very smart young man, and I must say, if one loses track or loses sight of the fundamental argument, um, you might buy into it. And I have to tell you, then I went down this rabbit hole. I went to their website because I was kind of curious now. Who is this organization? And their logo, have your best baby. And yeah, and it's driven by science, guided by love. And I thought, wow, okay, so that sounds so compelling. And so then I went back to the origins of eugenics and Julian Huxley, who's the brother of Aldous Huxley. And basically what Julian said back in 1936, sorry, I'm giving a little mini
Yeah.
a lecture here. Eugenics is about the enhancement of human potential. So just remember what I said about hair, eye, height, intelligence, and the reduction of hereditary defects. Screening to prevent heritability of illness. So as much as we think eugenics is part of the past, a dark past, maybe it's still very much with us. And of course, he would say he's a pronatalist because he says people who might be discouraged from having children might, on the basis of this technology, be encouraged to have children. So I don't know. I've given you a whole mini dissertation there. I mean, what are your thoughts on that?
Yeah, so I think it speaks to the era that we're in. Everyone wants perfection, everyone wants it and they want it now. So I can imagine designer babies being sort of in fashion. I think we're in an era where, yes, it's exciting. I can access information about anything in within seconds. We have AI where you can sort of have a conversation and have a human-like experience. Um,
Human-like,
and yes, human-like
not human.
experience, not human. And I think what comes with that is also with social media and how there's this strive for perfection with filters and altering your images. And I can imagine that having a perfect designer baby would sell. And because we also are in an era where uh, it's demand drives profits, and
Absolutely.
everyone is happy. um but I think in psychiatry it's complicated because the genes are just there are too many genes to sort of account for so many factors in nature versus
Yes.
nurture. Yeah, so I think that's where I don't know, I think the era that we're in will, I think our discipline will be the last discipline to sort of be taken over by AI because it's just too complicated.
Well, I'd like to think that we will tread cautiously when it comes to artificial intelligence. But I do get your point around perfection and striving for like a fault-free future. And so I can understand the anxieties that parents or future parents might have and their attraction to this kind of technology. And so I'm not saying it's good or bad. I'm just saying it's out there. But when we speak about eugenics as maybe something which we think of in the dark past, think again, because it's just maybe morphed into something slightly different in that sense, but maybe it comes down to the same thing. But I think what was really important about the forced or the compulsory sterilization was that it morphed into euthanasia. And I think that the very same individuals who were being sterilized were then subsequently, and I've got to put it in these terms, murdered over a period of time, and they used gas chambers actually to do that, and this was the predicate for the Holocaust which followed. So, psychiatry, looking back in terms of the history, unfortunately, there is this chapter which is a particularly dark chapter, and I suppose it's always important for us to be mindful of that. So the sterilization was a slippery slope, actually, and it morphed into something much darker, I would say. So I think the point, though, is this issue of ethics and ethical behavior, stigma, fear, and all of these kinds of issues. But obviously, getting into women and the child rearing years, you speak about unique needs. How would you characterize those?
Sure, that's very broad.
Yes,
I think why I'm also drawn to perinatal psychiatry. When I was still a registrar, I thought that I would do child psychiatry. And I know there are a lot of child psychiatrists out there who are kind of
yes.
upset that I didn't do
Okay.
child psychiatry. Um, but when I did child psychiatry, I started realizing that, we focusing on the child is not necessarily sort of solving the problem. It's sort of putting a bandage on the sort of a gaping
You're picking
wound.
up you're dealing with a problem which might have been dealt with differently earlier on, and there might not
Yeah.
have been that problem. I'm being idealistic there, but I mean, I,
Yeah.
I think that's
Yeah.
what you're saying.
Yeah. So what drew me to perinatal psychiatry is that intervention starts from preconception into
Yes.
pregnancy so that there's a better outcome in the postpartum, so that we actually it's sort of preventative and decreases the adverse outcomes in childhood that we see if we so that's how I view perinatal psychiatry. I mean, one of the things that blew me away at this conference in 2016 in Melbourne, Australia, was someone presented research on looking at studying the fetus's faces
Yes.
in the intrauterine period, and sort of trying to do to do mental states, just looking at the affect of the feet
Oh,
with an MRI.
fascinating. Okay.
I was like, wow, like just really blown away by that.
Sure.
And also simple
Sorry,
things that we,
I, I want to stop you there. What were their findings? Because now you're saying we're looking at the fetus in utero, we are monitoring their facial expression, and we're looking at their mental status in terms of the fetus. I mean, I've never really thought about that. So, what did they
yeah.
come up with? Can you remember what they said?
No, I think it was still research. They're still trying to sort of look for patterns.
Okay. All
And then they
right.
were linking it up to things that we do, that people do when
Yes.
there's a pregnant woman or a new baby, singing. Simple things like singing to the baby and, what it does. And, so some of the things that come naturally to us
Yes.
that we do, we're not even conscious of, how those things impact um the emotional or the mental well-being of the offspring that is to come. So yeah, so I think I was just sort of blown away by that, and
Yeah.
that's what I'm drawn to, that perinatal psychiatry is a form of preventative intervention, sort of to improve the caregivers'
Yeah.
mental well-beings. Because if they're well, then the chances are that the offspring will be well, and then we'll sort of limit the next generation of psychiatric patients.
I think that's correct, but you've actually just got me thinking about facial expression of the fetus in utero and linking it to specific stresses or specific events and how it impacts. And then I'm wondering, okay, if we kind of look at the sort of overall mental status, how do we then see the born child and what emerges thereafter? Because now we're starting to talk about potential factors which could augment good health in the fetus, not just physical, but mental health. So now you've got my mind going, but I've got to focus now because I need to get back to us and our conversation. So you had noted that, Marseille's comments way back in the 1800s, it was as if in the 19th century then, moving into the 20th century, things were kind of neglected. Certainly in the 19th century, things were neglected. And I mean, I suppose you have a point there. And then I came across, and it was research that I was well aware of in 2000, actually. Cliff Allwood, who was the former head of department at Wits, he'd done a PhD and he published a paper in the South African Medical Journal on puerperal psychosis amongst black women at Baragwanath Hospital. And I think that was the first local data. And that really started to put perinatal health on the agenda. And he came up with a couple of interesting risk factors. First, pregnancy, so the primaps, a family history of psychiatric illness, okay, a personal history of psychiatric illness, and psychosocial stress if the baby lands up in ICU or there's death of an infant. So he started to identify risk factors, which I think speaks to what you'd said earlier about the sort of interdisciplinary nature of perinatal psychiatry. So your thoughts on that?
So my thoughts on that is that generally, perinatal psychiatry, I mean, psychiatrists or people in the mental health space are sort of on board, but sort of preaching to the converted there. But the people who mostly see women in this space are your midwives, your GPs, and your obstetricians, gynecologists. And they're kind of scared. People are scared of mental health and scared of psychiatry. So,
Yes,
for example, if we speak about screening, mental health screening in pregnancy,
yes,
which should be standard and part of every woman's pregnancy experience in South Africa. Just 3 questions that need to be asked. Uh,
Not
most,
complicated.
yeah, not complicated. Healthcare professionals are scared to ask to ask those questions because then what? You know,
Well, that's
like,
a good
okay,
question.
she's suicidal now. Where must she go? The psychiatrists are not here. You know, most places the psych ward is somewhere far hidden, or the
Sure.
psychiatric hospital, and which pregnant woman is going to, you know, spend extra taxi fare to go and access those services. So what then happens is there's an avoidance of
Right.
screening. So we're not screening adequately. Despite the high prevalence, we have such a high prevalence of depression and anxiety during pregnancy. Yeah.
I was looking at those figures, and I want to come to them shortly because they were like, whoa, okay. So I think that what you're saying is there is a reluctance in terms of the extended multidisciplinary team to actually go there, because then what do you do with that information? And I suppose that's got to do with education. That's got to do with liaison and support, so that one is forming a network, so that it's just routine and we do this. And if this is what is found, then that is what we do next. So there's a very clear pathway to care, appropriate care for the pregnant mother. So I suppose, you know, certainly in this country, and it's not something unique to us, but it's the whole issue of resources. And I think resources do impact tremendously in terms of one's willingness to engage more, because that's what I'm kind of hearing is that, okay, so, and also confidence. So what do I do with this? But the less you do it, the less confident you are, the more you avoid it. And so how do we break that cycle? And I suppose that's where the society that you're president of, with its multidisciplinary ethos and involvement, is a very important starting point for that.
Yes, no, definitely. So, I mean, even my experiences when I ran the maternal mental health clinic at Rahima Musa Mother and Child Hospital, I came to learn that it's a whole host of things. It's fear, it's stigma, and sure, we are overburdened currently with there's too many patients and not enough healthcare professionals, not enough midwives, not enough obstetricians, not enough time. You know, but Prof, if you recall, Dr. Karina Marseille, she did a
Yes.
PhD, you know, looking at the Woolies questions and sort of, you know, validating. So basically, it's just 3 screening questions that get asked in the that can be asked during pregnancy to mothers, just a quick screening to sort of determine if there is an underlying mental illness that needs further assessment. So,
Yes.
one thing that stuck with me from her PhD, I think I forgot about everything else, but the most important thing that I took from her research was that most patients just want to be asked, just asking them, how are you?
Yes.
You know, how are you feeling? Uh,
Yes. Not just from a physical point of view, but how are you doing?
how are you doing? How are you
Yeah.
feeling? Like, you don't have
Yeah.
to be like a whole clinical psychologist or psychiatrist. You don't have to have
Yes.
a lot of experience. So just asking, how are you? How are you doing? Mattered to the patient cohort at that time. So even if we have limited resources, you know, we still can sort of, as you say, get our colleagues on board to say, guys, you don't have to do a full sort of psychiatric history, and they're not
Yeah. And a
expecting
mini
that.
mental status. No, absolutely.
Yeah, yeah. But just how are you doing? How's the pregnancy going? But I think healthcare workers are so overburdened that they don't even ask those questions. So you have pregnant women who are carrying all of this, and then it's
Yes.
unfortunate that it's too late when she delivers, and then now it's a psychosis or a mania or a suicide. And then everyone's scrambling, at that point. So that speaks to what I've said earlier, in that, you know, perinatal psychiatry has a lot of preventative. It's basically a preventative medicine. There's a lot of things that we prevent just by addressing uh, perinatal mental health.
I think that it brings me to something that I used to think about, which was because, child and adolescent psychiatry, because I did a lot of adolescent psychiatry, and I could have been a registered child and adolescent psychiatrist on the basis of that, but I decided not to. It always struck me that as much as child and adolescent psychiatry was kind of the junior partner to adult psychiatry, that's where adult psychiatry begins, actually. And I always thought how important child and adolescent psychiatry, specifically child psychiatry. But now, what you're telling me, and I'm really thinking about it, actually we go one step further back. We go perinatal psychiatry, and I think that's profound, actually, because it's something that, speaking of Karina Marseille and Alex Meister, I had a previous podcast, Beyond Madness, and we did an episode on pregnancy and psychiatry. And basically, what I'd understood through that episode and in our discussions was that actually maternal mental health is so foundational for what follows, for exactly the reasons that you're talking about. And so I don't know that is necessarily fully grasped in general, and whether there is that kind of awareness. So I think you're making a very profound point, but there were two specific issues. Firstly, the myth that pregnancy protects against mental illness, and I think that we've kind of seen that is not the case. And then the concerns about fetal exposure to psychotropic drugs and the inclination to want to stop. And then what are the consequences to the mother? And then as a consequence of consequences for the mother, what are the consequences for the fetus? And I think that whilst the fear may be understandable, I think one needs to look at the reality. So I think you mentioned the fact that, there's emerging data that says psychotropics, let's look at that carefully in terms of if somebody's on medication, where do we go once they fall pregnant?
Yeah, so I think we are in a space where we ethically have to weigh what are the risks of untreated illness versus the risks of the mother being on a psychotropic medication during pregnancy. And yes, we're looking at it through the lens of psychiatry, but there are also other negative outcomes or adverse outcomes obstetrically for the mother. If they say, we choose to say, okay, you're just depressed, or yes, you're just anxious, you don't need medication, or you don't need intervention, because intervention or treatment is not necessarily always medication. There are avenues for uh, psychology, but even in the private sector, going for therapy is expensive. There's not enough psychologists. So sometimes we do have to prescribe medication, just to get the person through. But ultimately, what when you look at the research, it's the obstetric outcomes, the adverse obstetric outcomes, if
Yes.
one has untreated mental illness, um, preterm labor, higher risk of cesarean sections. There's even studies looking at increased risk of postpartum hemorrhage, which is
Okay.
sort of life-threatening, increased risk of morbidity, ICU admission for the mother. That's just the endpoint obstetrically. If you look at it in the antenatal period, untreated mental illness, mom's not going to follow up at the antenatal clinic. Therefore, important sort of supplements, checks that need to happen in pregnancy don't happen. Untreated mental illness will result in the mother possibly having an increased risk of substance use during pregnancy. So it's sort of like this domino effect. If you just look at the risks of untreated illness, let alone biologically what happens if we elect not to treat mental illness during pregnancy, the cascade, um, the and the chaos and the havoc that it wreaks, yeah, in the already sort of vulnerable pregnancy state. And then you
So
go
there's a
into,
So there's a
yeah.
plethora of obstetrical issues, including low birth weight, and also coming into the issue of bonding and attachment, where you have a mother who has a psychiatric illness and her ability to bond and attach. And of course, there's always the risk of suicide amongst those mothers, and infanticide. You know, that's a phenomenon which is something which is not commonly spoken about, but is very real and tends to happen specifically. Some of the highest number of perpetrators are young mothers who are potentially unsupported and battling. So I think that your point is well taken in terms of, well, we can look at potential risk to fetus, and I think we've got increasing data that enables us to make rational selections and choices and to manage psychopharmacology in that period. But I think we have to look at the risks of untreated mental illness. So you've put obstetrics on the table. I'm adding some psychiatric, some dramatic psychiatric and other effects. And I suppose it's a balancing act, isn't it? I mean, it's about the risk of prescribing versus not prescribing.
Yes, and also let's not forget you just touched on some of the adverse neonatal outcomes, increased risk of small for gestational age babies, intrauterine growth restriction, preterm birth, ICU admission for the baby, bonding, child neglect, the rates of unwanted pregnancies in South Africa. On the news every other day, there's babies being dumped because these are unwanted pregnancies. So
Yes.
it's like a lot. If you look at the effects of untreated mental illness versus um, electing to look at, psychotropic medication. Obviously, specifically if we're dealing with severe mental illness, these are illnesses that need to be adequately managed in pregnancy to minimize those adverse outcomes. And everyone has to fall back onto us as a psychiatrist to say, look, this is how we manage during pregnancy this severe mental illness to prevent those adverse outcomes.
And I think these are important conversations that you have with your patients in advance of pregnancy, so that one, is forewarned, forearmed, and you're looking ahead. And you mentioned, the admission to ICU of the infant, and going back to Cliff Allwood's data, where that has a knock-on effect in terms of the mother and the potential precipitation of a puerperal psychosis. So it's all interrelated. But speaking about perinatal depression per se, and I was looking at the prevalence data, and I mean, they're talking about 30 to 40% in low and middle income countries, 10 to 20% in high income countries, and in South Africa, 30% antenatal, 40% postpartum. And I thought, wow. I mean, I don't know. I've always got an issue with such high numbers because I'm wondering to myself, how do you get to those figures? What are they using to make those determinations? I think that, one can look at percentages, but I think what's important to take away is that it's a very real phenomenon that's got to be managed. And I think that the use of antidepressants in pregnancy is something that has to be understood as serving a specific purpose. And again, we get to that risk benefit analysis that has to be undertaken. Your thoughts in terms of the figures and in terms of what I've just said now in terms of medication?
So the figures, yes, are shocking. But they speak to the states. We'll just take as us as South Africa, low and middle
Yes,
income country, even though World Bank says we're a middle income country.
somewhere, in some places.
Yeah, so there are lots of factors. Like psychiatry is also quite a sort of a social illness in
Absolutely.
that
Biopsychosocial. Absolutely.
if there's social ills, they kind of sort of spill over into mental health. So Our unemployment rates are skyrocketingly high. You know, we have a high rate of unemployment. We have a lot of people leaving rural areas, coming to the big cities to, look for employment. So it pulls them away from family support structure and living under really terrible conditions. You know, we have um, a lot of shack communities mushrooming around in urban areas, um, single people trying to, make a better life and then falling pregnant along the way and not having support. Um, I think that contributes quite a lot
To
to
those figures.
those figures and how we cope, as a nation. I think that transgenerational trauma is huge in South Africa, given the history of apartheid and what it has done. So this transgenerational trauma is still something in on the back foot, and it's a pity we don't have current prevalence studies of sort of mental illness in our current sort of population. But I think the those that the statistics of that would probably be similar to what we are seeing in the in the perinatal population.
Well, I mean, I'm going back to the South African stress and health study, which goes back quite a few years, and they were saying that 10% of all South Africans during their lifetime will probably experience a depressive episode. But I mean, that's a lot of people who are potentially impacted. But I mean, there were other issues besides poverty, food insecurity, limited social support. So you've alluded to that, and of course, gender-based violence and HIV also come into the mix. And so there are a lot of social factors which impact upon emotional state and emotional well-being. And so the question there is to what extent we need more social workers. We need more social support. It's not just about psychiatrists and psychologists. There are other groups of allied health professionals. And so I think that, again, we come back to the issue of resources. And who's going to put those resources into the situation? Government? Civil society? You spoke of Simone Honigman earlier, and she's got the Perinatal Mental Health Group, which I think, or the project, the Perinatal Mental Health Project. And I mean, I've seen their most recent newsletter, and I mean, they do tremendous amount of work. And I'm thinking, well, if they didn't exist, who'd be doing that work? And that's a real concern, because I think you also contrast what happens in countries like Australia, the UK, and even India. And maybe you want to just touch on that a little bit.
Yeah, so I think resources are an issue, but when you engage with people from sort of your high income countries, you start to realize that you'll never have enough people, you'll never have enough resources. So, we have to work with what we have. So, I mean, at that conference in 2016, I had the privilege of visiting a mother baby unit in Australia. So, in Melbourne. So, mother baby units are basically an intervention for mothers with severe mental illness who sort of give birth. Where do you admit them to? You can't just stick them into, your average psych ward. So they've created a specialized sort of inpatient unit where the mother's there, the baby's there, the whole team is there to support this mother during this time. It's multidisciplinary. It's super expensive. Yeah, because their most expensive resource is the human capital, because you
Yes.
need sort of lactation specialists, OT, psychology, someone to sit with the father as well, the psychiatrist, the gynae, and like it's a whole team of people,
So this is another kind
all
of multidisciplinary team.
Yep. And countries like Australia and the United Kingdom are privileged enough. So if mothers who have severe mental illness in the postpartum complicate, at least they go to a unit where there's encouraged sort of they treat the dyad, which is the mother and the baby together. Whereas what happens here is mom gets admitted to the psych ward, and what happens to baby, what happens to the bonding process. And then you contrast India. I was also privileged enough to go to Bangalore, where there was also a Marseille conference. This was in 2018, and to see how they're similar to us, wide gap between rich and poor,
Yes.
also low and middle income country, sort of extremes. They have the best of everything and the worst of everything, and limited resources. And I learned from that psychiatry is also sort of, you also need community intervention. So they have mother baby units, but they use the community, to support. So they'll have carers supporting. So yes, maybe not a clinical psychologists, but a carer who is just there to support the mother through the process. So they use what they have to try and support mothers during this time. And I mean, just like India, just like us, also has high rates of intimate partner violence, gender-based violence, and you know um they find ways to navigate through sort of community-led interventions, um, which are driven by community and not necessarily just relying on the psychiatrist or the obstetrician or the clinical psychologist to provide. So it's also the reason why we have to sort of reframe how we think about perinatal mental health interventions. If you look at in Zimbabwe, they have this concept called the friendship bench. So mothers go to an antenatal clinic, and there'll be sort of like an elder in the community, a woman who would sit on the bench. And if, let's say, the patient or the moms just want someone to talk to, you just go and you sit on the bench. And basically, this it was actually a psychiatrist who created this initiative. I forgot his name.
No,
Uh,
no, I've actually
um,
seen it. I've actually
yes,
seen it, and it was interesting.
yeah, so he's just trained lay people in the community on, interpersonal therapy sort of concepts, and just weaving that into the concept of the friendship bench. So why I bring these stories to light is that we need to look at our communities. I mean, in the Gambia, which is a small country in West Africa, they have a woman singing group. So in that community, culturally, women, especially women of childbearing age, have these sort of women's fertility singing groups. Um, and they realize that music therapy in itself sort of improves the well-being of mothers. So women who are pregnant, join these groups, and they sing. I think it's called the Chime Study. So why I'm bringing these to light is that you don't need to have money to provide perinatal sort of mental interventions, and we just need to now come up with something that's uniquely South African and sort of work with what we have, and sort of involve as many people as possible to coming up with solutions.
Well, they say necessity is the mother of invention. So I think that, lack of resources means that you have to be resourceful. And that's what you're describing. You're describing how local populations come up with local initiatives that are relevant to their population. But thank you for explaining the mother-baby unit, because I was thinking to myself, isn't a maternity ward a mother-baby unit? But of course, you've given it a whole new spin. So I actually understand far better what you're talking about. It's a highly specialized unit that is very well resourced with a lot of, as you said, human capital around the mother who might be struggling. And I think, I don't know what the data looks like in terms of results, but I'm sure, I would hope that it has a profound impact. So I wanted to close with something that we alluded to right at the very beginning, which is paternal mental health. And, men are often excluded, but they do impact the developmental outcomes of children. And you speak about a need for inclusive family-centered services. Your comments on that?
Yes, I completely agree. I mean, as you know, with the latest statistics that have come out in South Africa, that 2 out of 3 households of families that they're no fathers. It's sort of mother-led households. Um, so yeah, highlighting that we are neglecting men and their part in terms of parenting and the processes thereof, and also even though they don't carry the babies, they too also get affected, and men's mental health, specifically during the peripartum period, is also crucial to also support the mother and the birthing mother, and also support. So I mean, they also, in terms of after birth, there is an attachment that happens with fathers. um Oxytocin levels also get released. There's also a bonding that takes place, um yeah, and an attachment that happens for the baby and the father. So basically, it's just going back to what we know, what we've known, evolution, from an evolution point of view, the
Yeah.
family unit. We
Yes.
if we analyze it as, we just need to restore the family unit. When we restore the family unit, we will have a healthier and stronger nation.
Well, I
Yeah,
think I
that's
think it just
it.
provided these are healthy family units, then we have more stability. And of course, one mustn't forget grandparents. I think grandparents are also very important in terms of they bring something different, but they also bring the so-called institutional memory, good habits, bad habits, whatever, but they bring that wisdom, hopefully, which also makes a huge difference. But I think that the take-home message for me from our conversation is that if you neglect maternal mental health, you are impacting not just on women, you're impacting on children, you're impacting on families, you're impacting on society generally. And I think that for me is the very powerful message that I'd like to emanate or radiate actually from this conversation. Would you concur?
Yes, I concur. Or in summary, I just like to say happy mommy equals happy baby, and that's all we want.
Sure. Well, I've also heard it said happy wife equals happy life. So, so Lavinia, I want to wish you all the best for your term as president of the International Marseille Society, and I want to wish you all the best for the upcoming conference. I hope it goes well. And obviously, as editor-in-chief for South African Psychiatry, I'll be looking to you to keep me updated so that we can keep our readership updated. So once again, thanks for joining me. It's been wonderful seeing you, and all the best. Thank you for being part of this conversation. I hope you found it informative. Until next time, please feel free to comment, do subscribe, and as always, take care.